All right, let's do that. So welcome everybody. Welcome to the first Data for Good Data Science Institute seminar of the semester. We're very happy today to have Peter Frazier from Cornell's Operations Research and Information Engineering Department. Peter is also a staff data scientist at Uber. And today he'll be talking about a work project that he's been leading that led to Cornell's decision to fully reopen the semester. So obviously a topic that's of great interest to everybody here. So, and we'll hold most questions till the end. You know, if you have some clarifying question, you can try typing it into the Q&A box. But for the most part, we'll try to leave the questions for the end. So Peter will leave some time at the end for questions. So Peter, all yours.
Wonderful. Thank you, Paul. It's a pleasure to be able to be here, and thank you very much for the invitation. So I want to start out, and for folks that maybe aren't familiar with our small town, so I come from Cornell University, and we are in the state of New York, like Columbia, but we're in the middle of the country. So it's about a 4-hour drive from New York to Ithaca, where Cornell is located, and relevant for what I'm going to talk about is the fact that Ithaca is a city of, you know, depending on how you count students and count surrounding towns, is about, you know, between 50,000 and 100,000 people. The county is considered to have 100,000 people, and nearby cities are, you know, at least an hour's drive, and so we're what we call centrally isolated. Over the summer, universities, you know, around the country and around the world, at least in the Northern Hemisphere, needed to decide whether to reopen for residential instruction, and you know, and then if they decided to reopen, to decide how to reopen. And you know, especially if you're associated with Columbia University, and, you know, especially if you live in New York City, I'm sure that you remember, you know, how difficult a time that was and how difficult a time the spring was. You know, in Ithaca, we didn't have anything approaching, you know, the sort of devastation that you had in New York, you know, and so I can only imagine. You know, but as difficult as it was for you, you know, it wasn't quite as difficult for us, but still, you know, a challenging time. So data science played a really important role in the decision-making at Cornell about what to do. So I'm showing you a Wall Street Journal editorial that was written by our provost, Mike Kotlikoff, and our university president, Martha Pollack, talking about the modeling that the group that I lead did that informed Cornell's decision. So that, you know, the title of the editorial is "Why Cornell Will Reopen in the Fall." And I'll get into this analysis, you know, actually towards the end of the talk. But essentially what the modeling that we did said was that, surprisingly, it would be safer for us to reopen the university for residential instruction than it would be to keep it closed, with the main line of thinking being that if we only open for virtual instruction, so, you know, if we closed, then a substantial number of students would come to Ithaca anyway, because it's, you know, it's a nice place, and in particular, it's a nicer place to be than perhaps living with your parents. And if we had a substantial several thousand students living in this relatively small town who were outside of the reach of the university, and we were unable to effectively pursue interventions like testing, then that population would be at risk of having an outbreak, and would actually be more dangerous than bringing back a larger fraction of students for residential instruction, where that residential instruction would allow us to keep a closer eye on them. So in addition to informing that decision, we also played a role in we designed Cornell's testing strategy. So the way that our strategy works for bringing students back to campus is first, when students arrive, we into town, we do arrival testing. So everybody gets tested at least once. Then, once they arrive and once the semester starts, we pursue a really aggressive asymptomatic screening protocol where all undergraduates are tested twice a week. Most graduate students, many faculty and staff are tested once a week. And then a handful of people who have more contact with undergraduates are also tested twice a week. People that seldom come to campus might be tested once every other week, or if you never come to campus, then once a month. And that asymptomatic screening protocol is a really important part of our strategy, and I think is sort of the primary driver for the effectiveness of that strategy. It was enabled by a capability that we had on campus. Our veterinary school has a large ability to do PCR, the chemical test that's used to test for SARS-CoV-2 virus. And that capability, coupled with a pooling strategy where we would take samples from multiple people, from 5 people, combine them together, run PCR on that single combined sample, and then if that combined test came back negative, we could exclude all of the people that were included in it as having contributed virus to the sample. And then we only need to do follow-up individual testing on those pools that test positive. So that because when prevalence is low, that results in a roughly 5-fold reduction in the amount of PCR that one needs to do in order to do asymptomatic screening. So those two capabilities together enabled this strategy. And then also because, unlike New York City, we're a small town surrounded by farms, we can create a safe environment that's isolated, and as long as we aren't importing virus into that community, if we can control it locally, then that creates a safe environment for residential instruction. It seems to be working so far, knock on wood. So what I'm showing you here is in the top plot, the number of tests done per day for people living in Ithaca by our vet school laboratory. Before the start of the semester, we were doing roughly 1,000 to 2,000 tests per day, partly in arrival testing and partly in some smaller scale of surveillance testing. Then once the semester starts, you see roughly 5,000 tests a day on weekdays and about 3,000 tests per day on weekends. During this period where we were only doing some testing, what ended up happening was that there were some subpopulations within our undergraduates, particularly athletes living off campus, some other individuals who live off campus and had frequent social gatherings with each other, where there were clusters that were created in those subpopulations. And so what you see is in this lower plot where I'm showing you the number of confirmed cases of COVID-19 per day, you see that the number of positives that we're seeing before the start of the semester is, on one day we had 9 confirmed cases, and as a fraction of the tests performed, that's by our standards a relatively high percentage, let's say 0.1% test positivity. And then once the semester started and we were able to ramp up testing to be able to test all undergraduates twice per day, we had a period of about a week where we were finding large numbers of cases. So finding large numbers of cases, but then that surveillance testing and the fact that it allows us to isolate infectious individuals and prevent them from infecting others then led to what we've been seeing more recently, where we kind of have an average of less than 1 confirmed case per day and test positivity that's quite low. So overall, the strategy seems to have worked. It's been, it's still relatively early in the semester, but I'm optimistic. So what I want to do is to, first of all, articulate a set of mathematical models that allow us to think about the spread of epidemic at spread of COVID-19 at universities, focusing first on universities that opened without aggressive screening. Then talk about the screening program that we instituted at Cornell and the modeling, mathematical modeling that supported it. And then try to give some takeaways from this work for people that want to impact policy using data science. So first, COVID-19 at universities that opened without aggressive screening. If you open your favorite news website, I'm sure that you'll find stories about universities that opened where there were outbreaks. University of Alabama had some extremely alarming numbers. University of North Carolina, fairly well known for having had to shut down early on during the course of reopening for a number of schools. And then in New York State, just up the road from us, SUNY Oneonta had a large cluster of over 500 cases. Here's a less anecdotal, more comprehensive map of outbreaks at universities and colleges across the United States, compiled by the New York Times. And so you see that there really have been a large number of outbreaks among schools. So why does this happen? So the approach that most other colleges that decided to offer in-person instruction have followed, and I leave Columbia off that list because your classes are virtual. But the approach followed by most of these other colleges and universities was, first of all, many of them tested students once on arrival. Then, whenever a student presents with symptoms, for example, a cough or a fever, that individual would be tested. And then positive cases found through those two strategies would be reported to the health department. Those individuals would be isolated, and interviews would be done to identify the people that they had come into close contact with. And then those individuals would at least be quarantined and then might also potentially be tested in order to find new cases. So let's understand that with an animation. So here's a graph where each node in the graph represents a person, a student, an undergraduate student. And students that are colored pink are people that do not have the disease, have not yet had the disease. And the person who is pink has been exposed. So perhaps they live on campus, they traveled to Florida and came into contact with an infectious individual. They have the virus growing in their body, but the time since exposure is short, and so they are not yet infectious. They are not yet producing enough virus for it to leave their body and go and infect other people. After another day or two, that person becomes infectious, but does not yet have symptoms. They have no idea that they're sick, and that's one of the most dangerous things about this disease. So then the people that they come into contact with, represented by the links in the graph, can become infected. So for example, this person's roommate might become infected, then the person's significant other, a friend that they that they run with, these people all become infected. Then finally, this person starts to show symptoms, and they go to the doctor, they get tested, the health department becomes aware of that positive test, and then they isolate this individual. They ask them who their contacts are, and the person kind of enumerates the list of places that they've been and who they've been with, but it's hard to remember everywhere you've been and every single person that you've come in contact with, and you might not even know all of them. If you go to the grocery store, you don't know everybody that you come within 6 feet of, and also in a university situation where there are consequences for people that violate rules about social gatherings, if you've been to a party or you've hosted a party, you might not be willing to tell the health department that fact. And so for this reason, not all of the contacts are going to be identified by the health department, and therefore not all of them will be quarantined. And then because we're missing infections, those individuals can go ahead and spread the disease across the rest of the network. So why does contact tracing miss cases? Identified carriers might not remember or know their contacts. Contacts might not answer their phone when the health department calls them. That sounds simple and benign, and why can't we fix that? But actually that's a big problem. Also, carriers are typically infectious and are most infectious before becoming symptomatic. So the number of contacts that they have can extend, relatively far back in time, several days or even a week. Carriers may also, infectious individuals may be, symptomatic. They might have a little bit of a cough. They may not feel that great, but the symptoms are not severe, and they might think, hey, it's just allergies, or, I caught an upper respiratory infection. It takes time for me to go to the doctor, and so they might not report their symptoms. And then especially in a university environment where a very large number of people are between the age of 18 and 25, people in that age group often are asymptomatic. The asymptomatic rates for those people are even higher than the number in the general population, and the number in the general population is roughly 40%, 50%. Right, so why might contact tracing be even more likely to miss cases at college campuses than in general? Partly because young people are more likely to be asymptomatic carriers. Also, young people, it's documented in the social science literature, tend to have more contact with other individuals than others, than older people. And also there's evidence in the social science literature that young people may tend to comply less with behavioral restrictions like mask wearing and limits on social gathering size. On the other hand, in a university environment, behavior is more monitored and controlled than in the general population. It's not, monitored and controlled perfectly, but certainly if you compare a student living in a residence hall where there's a graduate student or a, staff or faculty member who is an RA, that person is going to be monitoring that young person more than perhaps if that person were living on their own. Also, young and otherwise healthy people can be, there's some evidence, although it's unclear, that they may be less susceptible to infection, and also they may have lower viral loads and may be less infectious when they are infected. So that hopefully gives you an intuitive understanding of why we see outbreaks in general and why we see outbreaks at colleges and universities. But we'd like to start to quantify some of these effects. And so to do that, I want to talk about two different kinds of mathematical models. One that is fairly complex, and the other one of which is quite simple. And I'm a believer that it's important to have both of these models, because the simple model is easy to understand, and the understanding allows you to make fast decisions and build intuition. Whereas the complex model, in exchange for that complexity, you give up the kind of intuitive understanding, but if you set up the model in the right way, you gain more accurate quantification of the magnitude of the effects from the model. So first, the more complex model. If you're interested in using this model for work at Columbia or work elsewhere, it's available on GitHub. It's what we call a compartmental simulation. It's a stochastic compartmental simulation where individuals are described by, first of all, a disease state that matches the animation that I showed you before, where people move from being susceptible to actually being exposed but not yet infectious. Then we think about a setting where they can become detectable in a PCR test but are not yet infectious. Then they're infectious and detectable And then they move into one of two symptomatic states, after which they either recover or unfortunately they may pass away, in which case they would be removed. But in either case, they're no longer, we model them as no longer able to infect other individuals. So we track people by their disease state and also by whether they are in quarantine or isolation. There's a technical, isolation is what you do for a person that you know is sick, and quarantine is what you do for a person that has been exposed to somebody that you know is sick. So there's a legal distinction between those things. So we track people by those characteristics, and we also track them by how long they've been in that state or in that compartment. And this allows us to model transition times that are not exponentially distributed. And then we also have a version of this where people are separated by the subpopulation in which they live. So for example, we model undergraduates differently from staff and faculty because first of all, the severity of symptoms that a young person would have is very different from the severity of symptoms that an older person would have. So if you're interested in knowing the number of people that are going to be in the hospital, or in understanding mortality that is likely to result from a collection of interventions, it's important to separate people along that kind of line. And then we also separate people by where they live, because that's also an important determinant of the amount of contact that they have with other individuals and who they come into contact with. So then the simulation produces these kinds of stochastic sample paths where we can, for example, graph the number of people that are in the general population that are infectious, the total number of people that have the disease, including both the green people, but also the infectious people that are isolated, and the people that have been exposed but are not yet infectious. We can also graph the total number of people that previously had the disease but are now removed or recovered. And then adding all of those up, we can track the cumulative number of people with COVID. And then using these simulations, we can apply different interventions, in particular contact tracing and asymptomatic surveillance. So if you're running a university where you're testing symptomatic individuals and then contact tracing them, here's what happens when your contact tracing doesn't find a large enough fraction of contacts. On the left here, I'm graphing the fraction of the population in blue that have ever had COVID. And you see very rapidly that you get exponential growth, at least through this early period when a large fraction of the population is susceptible. And then at a certain point, a certain very horrible point that we never want to reach in reality, the growth of the epidemic slows down because many of the people that each infectious individual comes into contact with has already been infected, and so is no longer able to be reinfected, if you assume that that you can only be infected by COVID once. And then you reach a point at which the epidemic stops spreading, and it's typically at a very high fraction of the population. And for the parameters that this particular simulation was run with, it's about 75% of the population. So we call that herd immunity. This is a bad situation that we definitely want to avoid. I will say, so these results come from the stochastic simulation that I showed. You see a little bit of wiggling in some of these lines, but they look very smooth. And that's because of the law of large numbers. So we leverage that fact following work by many epidemiologists. And in addition to these complicated stochastic compartmental simulations that, maybe take an hour to run, we also use simple differential equations. So here's a really simple differential equation model that reproduces a lot of the important dynamics and that we can use in order to get a really good intuitive understanding of epidemics. So it's called an SIR model. There's a state vector which contains three numbers that sum up to 1. The fraction of the population that is susceptible, S, the fraction of the population that's infectious, and the fraction of the population that's recovered. I'm ignoring people that have been exposed and are not yet infectious. There's another slightly more complicated model, differential equation model that does that, but I'm just going to explain the simplest useful thing. Then the dynamics of this model are that on any given day, each person comes into contact with beta other people. So what ends up happening is that the total fraction of the population that is contacted by an infectious individual on any given instant in time t, I should say, I'm talking about sort of discrete time, but when we think about the continuous time analog. So the rate at which people in the population are coming in contact with other people is beta. So the rate at which infectious people are coming into contact with other people is beta I. And then the fraction of those people that are susceptible is S. So this overall product determines the rate at which the susceptible population drops. So you get this, ds dt is minus beta IS. And then the infectious population grows at the same rate. And at the same time, the infectious people recover. Let's say that they recover according to exponentially distributed infectious periods. So the rate parameter of that exponential is, let's call it gamma. And so in the corresponding large population limit, we're going to see a fraction gamma of the infectious population move from being infectious to recovered per unit time. So we get this differential equation for the rate of growth of I, and then recovered grows at a rate of gamma times I. So if you solve this differential equation, using your favorite numerical method, or if you're lazy and you just look up some solutions on Wikipedia like I did for this talk, you'll see graphs that look very similar to the results from the stochastic compartmental simulation that I showed you previously. And if you're less lazy like my PhD students are, then actually, when you run this, you get good agreement. So this SIR model and also the slightly more complicated SEIR model does a relatively good job of reproducing the dynamics of a higher fidelity simulation model. And then you can use this SIR model in order to understand the conditions under which an epidemic happens. So if you just recall that, maybe there's two ways to understand this. So first, if you just recall that the infectious period is an exponential random variable with rate parameter gamma, then the infectious period lasts on average 1 over gamma days. And beta is the rate at which you are transmitting infections. So the total number of people infected by one other person, the total number of additional people infected by each infectious person is then the product of this number of days times the rate per day. So you get beta over gamma. And we call that, that's the number of other people you infect if the rest of the population is fully susceptible. We call that the R naught. And something that hopefully is relatively easy to understand intuitively is that if the number of other people that each infectious person infects is more than 1, then those are the conditions under which you get exponential growth of an epidemic, and where you'll need to wait for herd immunity before you get epidemic control. You can also see that formally from the differential equation, right? So you recall that di dt is this expression here. Plug in S naught is equal to 1. And you get that, the rate of growth is just beta minus gamma times I, which, you can rewrite as, some constant times R naught minus 1 times I. So if this thing is strictly positive, then when you solve this differential equation, which is an approximation to the solution to the SIR model, at least at the beginning when everyone is fully susceptible, then you're going to see that that solution has exponential growth. Okay, so this will grow into an epidemic if and only if R naught is strictly positive. So you can build on this model in order to account for contact tracing. So imagine that we now have two compartments that people move to when they are infectious and not isolated or quarantined. So there's a rate alpha, which is the rate at which people report symptoms. And then each time you have an individual that reports symptoms, there's another parameter n, which is the number of the average number of new positive cases found per contact trace. So then when you put those two flows together, what's going to happen is that I'm going to get a rate of flow from the infectious and free compartment into the quarantine or isolated compartment, whose rate is, alpha times 1 plus n times I. Okay, and then we also get the people that recover without reporting symptoms, gamma prime, moving out of the infectious and free compartment. So what really matters in this is that the people that end up in these compartments never come back. This is an absorbing state. And you can do the same algebra that I did with the SIR model without contact tracing in order to define an effective R naught. So that's the net number of secondary free infections that result from each primary infection, right? So that's just, the number of secondary infections. So that's the same R naught number, beta over gamma. And then you subtract off the number of additional infections that are found through contact tracing. So from each report, you get n, and then the probability that an infectious individual reports their symptoms is just alpha over alpha plus gamma prime. And if you do the same algebra that we did before with the SIR model, you get a prediction that you're going to see exponential growth in this world with contact tracing if and only if this effective R naught is strictly positive. Right? So, in this picture here, what we have is that this single individual infected 3 people, so R naught is 3, and then one of those positive individuals was found through contact tracing. So we take 3 minus 1, and that gives us the effective R naught, which is strictly positive, and that's going to predict that this epidemic will grow exponentially fast. So it's important when you care about the results from a model, and it's not just a mathematical exercise, to plug in numbers and to ask what it says about your real world. So, a reasonable number from R naught in a world pre-social distancing is about 2.5. And, in the general population, estimates vary, but let's say the percent that are symptomatic is about 65%. Okay, and then let's assume optimistically that all symptomatic cases seek care. Then when you plug in numbers, you get that R naught, is 2.5 times n times 0.65. And then when you try to figure out what does this number need to be in order to bring the effective R naught below 1, it needs to be a really large number, right? It needs to be a really large fraction of the number of cases, which is really putting a huge burden on the health department, putting a huge burden on contact tracing, which is not really a realistic burden for them to be able to carry. So what this kind of very simple analysis is saying is that unless you can make your contact tracing really, really good, you need to bring down R naught, with social distancing and masks, in order to be able to get epidemic control, unless you're going to do something else, unless you're going to expand the set of interventions beyond symptomatic self-reporting and contact tracing and social distancing and masks. So that brings us to what we did at Cornell. So beyond the approach of other schools, we test all students, including those without symptoms, which is pretty much everybody, twice per week for undergraduates, and once per week for most graduate students. We then do traditional contact tracing, and then we also do what we call adaptive testing, which expands the scope beyond traditional contact tracing and tests not just those people that are revealed to be close contacts according to an interview by the health department, but that include pretty much everybody in a sort of reasonable social circle around the positive case. So if somebody on the wrestling team tests positive, that wrestling team member, that wrestler says that they've only been in close contact with their housemate and their best friend, you might go ahead and test everybody else on the wrestling team, because first of all, there may have been contact that you don't know about, and second of all, because you want to jump ahead of the virus. You don't want to, if it turns out that the best friend of the wrestler is positive, and then that best friend has two other contacts, both of whom are positive, and then those people have more contacts. You want to encircle the epidemic and not wait for the results of that arduous contact tracing. That's a really large number of tests. Not every school is going to be able to do that. At Cornell, it's enabled by a really large PCR capacity that we had at the College of Veterinary Medicine that was created actually for testing dairy cows and other kinds of production sort of animal husbandry sort of efforts, and also pooled testing that I talked about at the top of the talk, and also collaboration with the local hospital that was really important for being able to set up the IT infrastructure for doing all this. Adaptive testing, right? So this goes beyond traditional contact tracing, where what we would do is instead of just testing these people that came back on an interview, we would test the whole social circle, right? So that we found to be a really effective way to be able to control epidemic spread that requires more tests than traditional contact tracing, but less tests than aggressive asymptomatic surveillance. And then screening, right? So what happens if we miss somebody in adaptive testing? Well, if we're testing everybody twice per day, then the virus can't get very far in the period between those tests. And that gives us also robust control. So let's try to understand that with our mathematical models, right? So we can definitely run, and we have run in detail, our stochastic compartmental simulation, but let's try to get a really intuitive understanding of this so that we can do kind of quick mental math. So we can build the same kind of differential equation that we did before, where we have flows from infectious into recovered. In this setting, just for simplicity, I'm going to assume that there's no contact tracing, but you can do the same thing with contact tracing and screening, but let's assume there's no contact tracing for the moment. So there's a rate of flow into the recovered compartment, and then there's another rate of flow from people being isolated via screening. And then I can bucket those two compartments together, and what I get is I get an overall rate of flow, which is gamma, that's the rate at which people are recovering, plus T. So T is the fraction of the population that I screen per unit time. And then the same kind of calculation that I did before with differential equations will show that I'm going to get epidemic growth if now beta over gamma plus T, this should be strictly positive. If beta over gamma plus T is strictly positive, then my effective R0 is bigger than 1, and I get exponential growth. So if you plug in numbers, and I say that, the original R naught is 2.5, let's say the average infectious period is, say, 10 days, then what I need to do is I need to screen at least 15% of the population per day. That's about once per week, okay? So our initial recommendation actually was to screen everybody once a week, once every 5 days. There's a substantial amount of uncertainty about all the parameters in these models, and it's better to be safe than sorry, especially when human health is the outcome that you're looking at. So what we actually do is we go ahead with 2x per week rather than 1x per week. Here are outcomes from our stochastic compartmental simulation that we ran over the summer, looking at testing everyone once every 5 days versus not doing asymptomatic screening and only relying on contact tracing. This is a histogram of the percentage of the campus community that would be infected by COVID-19. So fortunately, reality has turned out to be even more favorable than our models, but at the time, we projected roughly 5% of the population would be affected infected during the course of the semester if we had tested everybody once every 5 days, whereas 60% if we hadn't used asymptomatic screening. Here's a sensitivity analysis. Sensitivity analysis is a really important part of the work that we did, looking at how the percentage of the population infected varies with the percentage of the population that I test every day on a log scale, on a log scale. We had 3 different parameter settings to support this decision making. A nominal set of parameters, which we felt was our best estimate, turned out to be overly conservative, but at the time we felt it was our best estimate. Then an optimistic set of parameters, and then a pessimistic set of parameters. I spent a lot of time at night worrying that reality was closer to pessimistic than it was to nominal, but fortunately that didn't come to pass. Another important aspect of reality that we studied in detail using our more complex compartmental simulation, but that you can understand fairly well with differential equation models, is to understand that there are subpopulations in a university community, and there's substantial value in targeting screening towards those subpopulations. So for example, I can think about undergraduates in high density housing, dorms, fraternity houses, sorority houses. They have a lot of contact with each other. Then I might have undergraduates in low density housing. Maybe they have 1 roommate, 2 roommates. They have, more contacts perhaps than staff or faculty member, but more, but fewer than those in high density housing. And I could have, we had a number of other subpopulations. So you can extend the kind of model that I had before, where there's a flow of the susceptible population in each group to the compartment for infected individuals in each group, where the rate of flow is, first of all, proportional to the fraction of that subpopulation that's susceptible. And then those susceptible individuals can be infected by, first of all, people in their same subpopulation. So IT1, that's the fraction of the overall population, times the rate at which they come in contact and infect each other, beta 1,1. Now beta is a matrix describing the rate at which an infectious individual from a population on each column infects somebody in a subpopulation in each row, right? So I get this beta 1,1 times IT1. Similarly, people in subpopulation 2 can come into contact with and infect people in subpopulation 1. So that occurs at this rate, right? And I get a comparable sort of rate of flow for from susceptible to infected for people in the second subpopulation. Then people move from these infected populations into a recovered or isolated or quarantined, if you're including contact tracing into this, which is important to do in practice, because that is an important part of the interventions that we use, where people are recovering from their disease at this rate, but then also are being screened at this rate, right? And so the game is basically to choose these T1, T2s, et cetera, so that these flows are fast enough so that, you know, this thing doesn't blow up and cause exponential growth of an epidemic. So basically doing that, choosing all of these T's so that you prevent an epidemic, but at the same time, making sure that the sum of the T's, you know, or really the dot product of the T's with the sizes of your subpopulations remain within the number of tests that you can do per day in the laboratory that you have available to you. And then when when you're worried, going and calling the people that run the lab and begging them to, you know, add a second shift and to work on weekends. So here's what that looks like in kind of packaged together into a single differential equation. So this is a vector, and then, you know, we have the number of susceptible people here, also a vector, and then I have this matrix product, right? So that's giving me this thing. And then what I need is that when I plug in that everyone is susceptible, the resulting sort of upper bound on the rate of growth for the infectious population is just this quantity here. So if I want this solution to not have any components, you know, that are like e to a positive real number times time, the thing that I need is to make sure that all the eigenvalues of this matrix, you know, all of which are real because it's a symmetric matrix, those all need to be negative, or at least, you know, zero. Better to be strictly negative because, you know, there's parameter uncertainty. And, you know, that's a little bit complicated because there's like some eigenvalues involved and maybe it's a little hard to picture in your head. But if this is a diagonal matrix, which is mostly the case in reality, mostly subpopulations, you know, like if your subpopulations are undergraduates, graduate students, and staff faculty, then in a pandemic, you know, undergraduates mostly interact with undergraduates, graduate students mostly interact with other graduate students. You know, and you see that even in non-pandemic conditions from the social sciences literature where people estimate assortativity of contact rates. So basically beta, you can think of it as mostly diagonal. So then what this decomposes to is that beta I just needs to be less than gamma I plus ti for each I. So basically what you're doing is for subpopulations that have a lot of contact, basically beta I, or beta II really, just the rate of testing for those subpopulations needs to be larger. And so that's the main reason why we're testing undergraduates twice a week and graduate students once a week. Here are results from our stochastic compartmental simulation, looking at you know, higher fidelity version of this model, where what we do is we enumerate collections of different targeted testing strategies. For example, so each of these letters is a targeted testing strategy. For example, B in this graph means I'm testing undergrads in high density housing twice a week, off campus staff that never comes to campus once a month, and then everybody else once a week. What I can do is I can enumerate on my computer a large collection of those testing assignments. I can then trace out a Pareto frontier where I graph number of tests per day versus the number of infections that I expect in my university over the course of the semester. And then I can go to my lab. I went to my lab and I said, hey, you know, if you can give me more tests per day, if you can hire more people and make your processes more efficient, then, you know, we can get out here, we can get to this H or to this I instead of being here at B. And that's gonna prevent 1,000 people from being infected. We've also found adaptive testing to be an important part of what we're doing, especially in a period when we had less surveillance before the start of the semester. Here's some simulation results comparing basically the total number of infections that you expect in a population versus essentially the amount of contact that you have between individuals. And you see that, you know, if the amount of contact is relatively small, it doesn't matter. your other interventions are doing the job. But if you have a lot of contact, then you can get a factor of 2, a factor of 3 improvement. I'm going to leave time for questions. So maybe I will say that, I mentioned at the top that part of the work that we did was about designing testing strategies. The other part of it was to make the case that Cornell should reopen. And, the key part of this was that we felt that evidence strongly suggested that several thousand students would come back to Ithaca whether we reopened or not. And based on legal considerations, it seemed that it would have been really hard to mandate and then enforce asymptomatic screening for those students who came back under virtual instruction. And under a large, under kind of what we felt were the most realistic parameter regimes, we saw epidemics growing exponentially in that virtual instruction population. And so we felt that residential instruction was safer than virtual instruction. I think, that if we had been doing this analysis for Columbia, given that Columbia is in a large city, the conclusions would have been different. But I do think that this analysis is relevant for other college towns. Here's Michigan State, where they are not open for residential instruction. Students are asked to not come to town, except for a small number of students who are doing lab work, and I believe also some students in the law school. But still, a relatively large number of undergraduates have returned to town, and they've seen a big jump in COVID-19 cases, unfortunately. So this is, just along the lines of what we were worried about happening at Cornell if we hadn't opened. I'll just close with a couple of takeaways, things that we learned while doing this work. First of all, I presented these simulation models like, you just look at them and trust the results, but there's a lot of parameters, and the consequences for what happens to real people really depends critically on what those parameters are. And, especially at the time when we were doing this, it was really hard to know whether, was R naught in the student population before masks and social distancing 2.5 or 3.2. And that difference is night and day. So we spent a lot of time worrying about parameters, doing sensitivity analysis, trying to articulate to decision makers that even though we were, running simulation models and it was producing like really specific numbers, that, there was a lot of uncertainty. We spent a lot of time communicating with the community, some of which was sort of challenging, and it's a charged issue. You can read, how many members of the Cornell community exactly are the president and provost willing to let die to ensure a residential semester? And they're talking about the outcomes of our models. And so it's hard. You do your best to be able to support decisions as well as you can, but with important decisions, with a lot of uncertainty, you never know for sure what's going to happen. And so we spent a lot of time, communicating with people that had these concerns. So this is a blog where we, this is our response to one part of this question, kind of explaining the math about what we know and what we don't know. So yeah, that was an important part of what we did. We all, I spent a lot of time, this is an interview I did with the local newspaper. I did a lot of interviews trying to explain to the community the, kind of how much confidence we had with these numbers, how to think about them, how to think about our decisions, defending things that were well-founded in science, and just articulating that there was a limit to what was knowable, and that we were doing our best. Fortunately, there turned out to be many fewer infections than we predicted. So this is the actual number of infections since August 16th. This is a report we generate every day for the president. And these were all of our projections. So 117 versus, 380, 382, which is where I thought we would be on 9/17. So I'm hoping that we stay under. Just some final takeaways. So I think, you know, a lot of the time being an academic is about writing papers, but which is great. And I think helps the world in the long run. But if you have a real problem that you need to solve, my advice would be to decide whether you really want to solve the real problem or write the paper, and then orient yourself around that goal. Those goals are not fully aligned. So in this case, you know, we haven't written any papers yet. And, you know, because we were focusing on solving the real problem. You can have, second point, you can have a really complicated computer model, but also have a simple mental model of what that computer model is doing, because that will make you a lot faster and help you explain it and help you catch errors. Communication is really critical, so critical, and is worth your time and your effort. Understand that the people that you're interacting with have a political environment in which they're operating, and the decisions that they're making are constrained by that environment. And if you understand that and respect that, you can communicate with them in a way that is going to influence policy towards, you know, what you think is the right thing, and you know, it's gonna help you when they do things that you don't like. It's gonna help you understand that, and it's going to give you more influence. And then finally, I'll say that our decision makers, you know, the president is a computer scientist, and the provost is a microbiologist, and that background, as you know, as scientists, really helped our ability to influence the decisions that were made. You know, I really appreciate the work that they did and the steady hand that they had through this whole thing. And, you know, and so at the end of the day, it's just good to appreciate luck. So let me just thank everybody and remind you to stay 6 feet apart and wear a mask. I'll take any questions that you might have.
Thank you, Peter. Very important work, very clearly presented. So thanks for that. We did get a couple of questions come in through the chat and the Q&A while you were talking. Do you want me to read those to you, or do you want?
Sure. Yeah. Yeah.
So the first one was about what you're assuming about death rates.
Sure. We take data from the CDC, which has estimates of the rates of death, you know, broken out by ages. I would need to go back and look at exactly what numbers we plugged in there. What we found was that the number of deaths that were so if you take the kind of like the nominal model that we had, I believe the number of deaths that we projected when you just took a vanilla like version of that was, I think, like 0.3 deaths. And we didn't include that in the report because we felt like it significantly overplayed the amount of certainty that we had about deaths, because, you know, kind of like the phenomena in an undergraduate population is that, so, you know, what we see is that most of a substantial fraction of the people that are infected are undergraduates. Most undergraduates have most people in that age group have a really low fatality rate associated with the disease. But there are some individuals that have comorbidities. And I believe that the primary dynamics that go on when you think about, you know, like 2,000 undergraduates being infected, whether somebody dies or not, is really, a lot of it is determined by, you know, did there happen to be somebody who had a heart condition? Or did there happen to be somebody who was immunocompromised in that group, especially if that individual did not know that they had that condition. So, you know, if you were to, you know, and so if you're going to make like a histogram of deaths, it's got like a big variance. And so we didn't end up, we felt that hospitalizations was a more, and so like when there's an outcome that has a high variance and is like a relatively small number, I think that it's hard to base decisions on that small number. And we felt that hospitalizations was a better representation of was a number we could estimate more readily. And we felt it would be better, like if you're making decisions in order to minimize hospitalizations, you're basically also making decisions, except for making sure that you're protecting vulnerable populations. But even in that regard, still, like if you try to minimize hospitalizations, I think that's the same thing basically as trying to minimize deaths. So we've reported
So there was
that.
a related question about, did you also analyze some sort of rule for at what point you would actually shut down?
We did, yeah. So we do, yeah. That came later. The number is 250 cases over a week. And that was based on a sequence of simulations. It's basically, we think about it like it's like a sequential statistics problem. It's like sequential probability ratio test, where there's parameters in your environment, you don't know what they are. And what you're trying to do is you're trying to know, you would like to know whether those parameters are going to result in a widespread epidemic. And you're getting like stochastic noisy observations of kind of outcomes from the system that has those parameters. So yeah, we ran a bunch of simulations kind of thinking about that, looking at trying to design something simple, but that still kind of got the first order phenomena, where we would look at like number of cases over a week, and then kind of had a sequence of conversations with the president and other people in leadership about what the right threshold was. Fortunately, we're nowhere near that, but yeah, that's kind of what the number is.
And there's also a question about the student response to the twice a week testing. How's that going?
Yeah, it's going great. I think students appreciate being able to come to have a residential college experience, or at least, it's not a full college experience if you can't have like a raging party with a keg. But it's like kind of pretty close, and they appreciate that. I think in large part. The sampling that we're doing is it's interior nare, so it's not like all the way. It's not the nasopharyngeal sampling that is often used for testing people that are symptomatic. It's just the front of the nose, so it's not uncomfortable. And credit to our testing people, they have these amazing operations where you go in and it takes like 4 minutes. You're not in line. I think there are 7 sites around campus. So kind of wherever you live in town, it's easy to get to. So yeah, I think by and large, undergraduates are totally happy with the trade-off of being able to do that. You need to do that twice a week, but I think the thing that they'd rather have is to be able to have larger social gatherings, not have to wear masks. I think that would be the big win if we could get there.
Sure. And maybe one last question that came in was, do you have any insight into why things have turned out to be better than predicted? And of course, that's not unique to Cornell, right? I think down here in the city, things are also better than they were a few months ago, and I'm not sure anybody really knows why. But if you have any insights on that.
Through the summer, what would happen is we actually published a sequence of models, and I think there were 2 communities in Ithaca. There were people that wanted the university, felt that the university opening would be a good thing, and were willing and didn't think the risk was that high. And then there were other people that felt exactly the opposite, that if the university were to open, just that it would be the worst thing in the world, and that there would be significant loss of life. And a lot of those people are like university people, so to some extent they are informed by evidence, but at the same time, like, people are people, and you kind of like make a decision and then post hoc rationalize that decision. So I found myself in this situation where, like, and the people that were worried about significant loss of life, they were, I think, incentivized to spend a lot of time reading the things that I wrote, and complaining about assumptions. So there's like, whenever you do modeling, there's like a long list of assumptions, because the real world's a complicated place. And so like kind of at the beginning, like half of the assumptions were kind of a little bit too optimistic, half of the assumptions were a little bit pessimistic. And everybody like yelled really loud about the ones that were too optimistic. and nobody mentioned any, crickets about the pessimistic ones. So then I think we tried not to do this, but well, I think so. Then what would happen? And also, like, you're trying to make, on the one hand, like, if you make an error on the one side, you end up doing too much testing and it's expensive and it's a pain. But if you make an error on the other side, like, really, really bad stuff happens. So, every day when we made decisions about setting up the model, we try to bias towards the conservative side. So I think those two things together just naturally created a more conservative model.
Great. Maybe, so one last question that came in, and then we'll, oh, hold on, sorry. So there's a question about the sensitivity analysis and how important that was in communicating the results.
Yeah. So it was really important. Probably like half the work that we did was sensitivity analysis. Because with this, especially with the disease at the point in time in the summer, just like so many kind of basic biological facts and so many basic sociological facts, there was just so little that was known. So we felt that, the modeling wasn't even really a prediction. It was more just kind of like a thinking through what scenarios were most likely, and like what do you need to believe on the inputs in order to believe a thing on the outputs, so it's like a thought tool. So yeah, sensitivity analysis was absolutely critical in kind of the internal deliberations about stuff. And whenever we published something, we always did our very best in order to articulate the uncertainty and then to, feature sensitivity results prominently. Then it was also a really important communication tool with the public for, we did like a lot of town halls, where I would show, both with kind of faculty senate at Cornell, I did a couple of those, and then also just like general town halls, where, I'd get up there and I'd be like, hey, this is how the model works, and like, kind of, this is what we think will happen, but also there's all these things we really don't know. Here's a plot of like this thing we don't know on the x-axis and this y-axis. Here's another plot. Here's another plot. And then people would ask me questions, and I would pull up, the report, and I kind of help them talk through using sensitivity analysis. Like what. It was very upfront about the fact that we didn't know things, because we didn't know things. Yeah, it was critical.
Sure. Yeah. Well, sounds like really impressive work, and it's great to see that it's working out well. So it's thanks a lot for taking the time to tell us about it. Actually, inspiring work, and very, very nice presentation. Thanks a lot.
My pleasure. I hope to be able to come visit you guys in person when we're all back to
we look forward
back to real life. Yeah.
Absolutely.
Great.
Yeah, thank you, Peter.
Thanks,
I
Peter.
want to echo what Paul said.
For sure.
Very nice. Thank you.
Okay. Thanks, everybody.
Yeah, thank you. Bye-bye.